Hello, my name is Brad Quo. I'm with Mass General Hospital GI Unit and the Neurogastroenterology Department. And we're going to be talking about the optimizing management of gastroparesis, where we'll touch upon gastroparesis, functional dyspepsia, ARFID, and cyclic vomiting syndrome. We're going to talk about symptoms and definitions, a little bit about pathophysiology, and ultimately talk about treatment paradigms. So upper GI symptoms are numerous, but they include early satiety, anorexia, food avoidance, bloating and fullness, heartburn, chest pain, dysphagia, nausea, abdominal pain, weight loss, and vomiting. And these lead into potential clinical entities such as functional dyspepsia, gastroparesis, ARFID, or avoidant restricted feeding intake disorder, chronic nausea, and cyclic vomiting syndrome. Now, I think one of the biggest challenges that I deal with as a gastroparesis specialist is that many patients come to me with gastroparesis diagnosis, but the reality is it's a little bit more complicated. So let's go over the definition. Delayed gastric emptying in the absence of a fixed mechanical obstruction of the pylorus or small intestine, but you actually have to have upper GI symptoms of nausea, vomiting, abdominal pain, or early satiation, at least one, if not all of them. And so the key here is that if you have delays in gastric emptying for some random measurement, but you're asymptomatic, that is not gastroparesis. You have to have bona fide delayed gastric emptying measurement by a standardized test, along with upper GI symptoms. Compare that to functional dyspepsia. The latest version by Rome 4 is one or more of the following: bothersome postprandial fullness, early satiation, epigastric pain, and epigastric burning, and no evidence of structural disease, likely from upper endoscopy being negative, and symptoms lasting for at least 3 months with a symptom onset at least 6 months before diagnosis. So the bottom line difference here is that patients have the same symptoms, but one has a formal gastric emptying measurement with an abnormality, and the other one may or may not have a gastric emptying measurement. You can divide functional dyspepsia into two categories: postprandial distress syndrome, where it might include bothersome postprandial fullness occurring after ordinary size meals at least several times a week, and or early satiation that prevents finishing of regular meals at least several times a week. They may have bloating or postprandial nausea, excessive belching, and they might also have the other part, which is epigastric pain syndrome, EPS, another form of functional dyspepsia, where they may have pain or burning localized to the epigastrium at least moderate severity, at least once a week. The pain is intermittent. If it were chronic, it would be chronic abdominal pain. Is not generalized or localized to other abdominal regions, which might include IBS or general abdominal pain, and doesn't fill the criteria for IBS or sphincter of Oddi disorders. The pain may be of burning quality, but without a retrosternal part, and is commonly induced or relieved by ingestion of a meal, but may occur while fasting. It may have that postprandial symptom coexist, and it has to have at least 3 months of symptoms with the onset beginning at least 6 months before the diagnosis. So the symptoms are identical between gastroparesis and functional dyspepsia. The difference is the gastric emptying delay. And one of the common things that comes up for me is that the abnormal gastric emptying test has a broad range. We'll talk about gastric emptying test abnormality cutoffs, but the reality is for standardized gastric emptying scintigraphy, cutoff is less than 4 hours of less than 10%. And people come to me with labeled gastroparesis with upper GI symptoms, sometimes significant symptoms, but only 11% gastric emptying abnormality. So is a slight delay practically normal? In my book, it is. And essentially, even if they have 11, 12, or 13%, frankly, up to 14 or 15%, I consider that borderline and practically normal, and I will label those more as functional dyspepsia and try to categorize them as epigastric pain syndrome or postprandial distress syndrome. Now, the big question is, why do we bother measuring gastric emptying, and why do we categorize these people in functional dyspepsia and gastroparesis? The reality is this group of delayed gastric emptying probably flow back and forth between functional dyspepsia with mild or normal gastric emptying to gastroparesis, where their gastric emptying measure might be more severe. And that may not necessarily correspond to the severity of the symptoms. This is not unlike IBS-C versus constipation, where the primary complaint in IBS-C is pain with altered bowel movements, and constipation may have some discomfort, but the primary complaint is not pain. So here, in evaluating these patients with gastroparesis or functional dyspepsia, we're really looking at either pain versus nausea versus early satiation. Now, there are a lot of different causes of upper GI symptoms, ruling out mechanical issues, metabolic issues, diabetes, hyperthyroidism, electrolyte imbalance. Surgery can cause problems, whether it's partial gastrectomy or now what comes up often are bariatric surgeries, whether it's sleeve or Roux-en-Y. Asopeptic diseases, gastritis, collagen vascular diseases like scleroderma. A lot of different medications can cause dyspepsia and slow down the GI tract. I list a few here like anticholinergics and narcotics, but one big one that's getting a lot of press is GLP-1s. Pseudoobstruction can be a larger diagnosis contributing to gastroparesis, and it can be paraneoplastic syndrome. So I typically see if there's multiple delays throughout the GI tract, stomach, small bowel, and colon, then I start to think about pseudoobstruction and other paraneoplastic syndrome or some systemic cause. Electrical dysrhythmias can be documented, and CNS issues can cause problems. But by and large, many patients nowadays coming to GI clinics are more likely idiopathic, even though you still have a portion of patients that have diabetes, and that's a well-documented group of people, mainly managed by diabetologists and by primary care docs. The nowadays, GI docs are seeing much more idiopathic because diabetes is frankly under much better control. So this slide goes over the pathophysiology of gastroparesis and functional dyspepsia. I put both slash there because when we study both entities, the reality is many of these pathological issues come up, whether it be fundic hypomotility, issues with antral hypomotility, discoordination between the antrum and the pylorus and duodenum, issues with the electrical rhythm in the GI tract stemming from the pacemaker of the stomach, or maybe issues with hormonal or neuronal feedback with nutrients spilling in the small intestine or trickling there, causing upstream issues with function or sensation. And if patients have these symptoms for a long period of time, even though we focus on the pathophysiology of the periphery, the reality is these things can go furtherwards up through the spinal cord or to the autonomic nervous system, to the vagus, and eventually impact the brainstem and the cerebral cortex. And that's where things like psychotherapy and hypnotherapy and other central neuromodulators can take effect. But you also have visceral hypersensitivity generated by issues with tachykinins, opiates, capsaicin, NMDA receptors, possibly some fluoride channel modulation and TCAs. There's always the question of acid suppression. And how does this all play into gastric emptying? The reality is, I see gastric emptying as a function of neurological status in the upper GI tract. It can be abnormal with neuropathic conditions and probably one type of neuropathy, but it can also be neuro and still have a neuropathic condition leading to sensations of nausea, abdominal pain, and such, or bloating or early satiety without the delays in gastric emptying present. So really, we are trying to discern motor issues which define gastroparesis, whether that be dysmotility too fast or in gastroparesis too slow, poor accommodation where the fundus may not stretch, becoming too stiff, or an abnormal gastrocolic reflex. And this is where a common complaint, patients eat and they say they got to run to the bathroom a minute or two later, and that's not because the food runs through them all the entire GI tract within 2 minutes, but more because it stimulates a hyperreactive gastrocolic reflex. The stomach has food in it and it stimulates the GI tract below, got to make way, and it stimulates an aggressive bowel movement. This process happens normally in everybody, but heightened in potentially people with issues. This is in contrast to sensory issues where you do motility studies such as gastric emptying scan and find that it's normal. And here, without other evidence of dysmotility, now you're talking about sensory issues with the vagus or the autonomic nervous system or the spinal cord contributing to pain or discomfort, nausea. And this is where identifying this sets the stage up for nerve ending desensitization or neuromodulation. So the role of objective testing is to rule out structural issues, usually with endoscopy imaging, rule out GI motor issues with transit testing or contractility, mainly transit testing, and rule out other factors such as intolerance, celiac disease, challenges with FODMAP, and occasionally microbiota and SIBO. So what is a sensory issue? In essence, this is a wastebasket default, where if a motor issue is not identified and patients still have symptoms, then we consider it a sensory issue. And this is important because ultimately, this allows us to transition from just focusing on pure promotility agents to actually agents that can change the nerve ending sensitivity And I find this is one of the biggest points that I can offer as a neurogastroenterology subspecialist, is transitioning from potentially just pure promotility agents or anti-nausea agents to now neuromodulating them. But it takes time to set the patients up, to make them understand that this could be an alternative process, and to get them to begin trialing these medications, which can cause side effects, and people have to be coached through this process. I think that other things to look up, there oftentimes the upper GI symptoms are not in isolation. They could have esophageal issues or lower GI issues, necessitating other sort of mechanical studies. And then you could also take into account that the patient as a whole may have other chronic pain syndromes, whether it be GI pain syndromes, such as non-cardiac chest pain or IBS, or non-GI symptoms, such as fibromyalgia, migraines, chronic back pain, with associated anxiety and depression. So I think one of the biggest conundrums is that when you take a patient who's very symptomatic and you measure motor, such as gastric emptying, frequently there's a poor correlation between gastric emptying measurements and upper GI symptoms. There have been plenty of scatter plots showing that patients can have severe symptoms, but normal gastric emptying, and patients may have only mild gastric emptying delays, but severe symptoms. And that challenges the correlation between severe delays in gastric emptying and severe symptoms. It may describe a small portion of patients rather than the general patients at large. And so really, you wonder about the empiric idea about treating patients versus testing ahead of time. And treating a motility disorder by symptoms can be treating with laxatives that can help with upper GI symptoms. That's a big one that we see that we help patients with. Treating the heartburn with acid suppression, because that may be tied into the vagus sensitivity. And treating the nausea, early satiation, vomiting with a promotility drug or anti-emesis, anti-nausea medication. So again, the role of motility testing is to find objective abnormality to target treatment. If you have delay in gastric emptying, you can use prokinetics, or define an abnormality which may impact treatment options. If you define a delay in gastric emptying, how does that limit you in terms of choices of medications you might use? But what I find by far most of them helpful is the value of a normal test, where if the test is normal, there's no major motility abnormality, and really then I fall into the idea that this patient may have a sensory abnormality and focus on neuromodulation. So gastroparesis and functional dyspepsia, there's overlapping symptom presentation. Gastroparesis has to have symptoms with a diagnosis made with abnormal gastric function testing. Functional dyspepsia is a symptom complex, which is driven by how the patient feels, but you do not have to have a gastric emptying scan. In fact, if you measure it, most people are normal, but a portion of people may have delays in gastric emptying. As a result, with this overlap, there's an overlap with treatments. But let's talk about upper GI motility testing. Most common is scintigraphy. The standard is a 4-hour egg beaters meal where the cutoff is less than 10% at 4 hours. There are other things here, such as a wireless motility capsule, and more are being developed to replace what is sunsetted. Gastric emptying breath test, which uses no radiation, but there are some caveats. You have to be aware of gut inflammation, liver and pulmonary disease, because that can affect the modeling. And also beyond the stomach, you can measure small bowel transit. Now, the poor person's way of doing is measuring small bowel transit with a small bowel follow-through. Generally, the contrast is formulated to run quickly, and transit time should be less than 2.5 hours. In addition, you can rule out any small bowel structural issues that may be contributing to symptoms. By documenting small bowel transit delay, if it's severe, that's important. Because if you're thinking about bypassing the stomach and using enteral nutrition, if the small bowel transit is extremely delayed, then you're going to run into problems. You may have to relegate this person to TPN. On the flip side, if the small bowel transit is normal, and that's actually expected in most cases because the small bowel is the most resilient to dysmotility compared to gastroparesis and constipation, then you might trial enteral feeding. Now, it's not to say enteral feeding is going to be run smoothly. A lot of these patients try enteral feeding and they have severe pain and nausea, but that's not due to a dysmotility. That's due to a sensory issue of poor meal tolerance, because if they haven't used the GI tract in a long time due to avoidant or restricted behavior, then their body will feel terrible when they start challenging it with foods. It's much like if you were to have bed rest for 6 months. You cannot challenge a person to get a marathon done, and it has to be done in small increments. And that's why I frequently admit these patients, put an NJ tube in there and trickle the tube feeds in there and gauge their response. Sometimes they're champ and they go all the way up to 100 cc's an hour over a day, and that's great. We can send them home, and with the idea of maybe transitioning to a G to J tube. But other times, if they have poor tolerance, I don't give up. I actually neuromodulate them to get them to have better tolerance in addition to supplementing PO food. Now, medications that delay gastric emptying. This is a challenging issue because patients frequently are on a number of the medications listed here. These all can theoretically delay gastric emptying, some more than others. And do you get a gastric emptying measurement trying to strip these people off the medications before the test to get a bona fide, accurate measurement of gastric emptying? That is ideal, but at a practical level, stripping a patient off a lot of these medications is difficult. So oftentimes I do measure gastric emptying on some of these medications so I can get a test done. Frequently, patients, if they're not on these medications, can't even swallow the standardized meal, even half of it. And to me, some data is better than no data at all. And so a lot of the offenders like narcotics, anticholinergics can be difficult if they're chronic. And the big one causing issues now is GLP-1s. As you know, almost 1 in 8 of patients in America are on GLP-1s, and that will definitely cause delays in gastric emptying. I mentioned different ways of measuring it. The key one here is the 4-hour measurement of less than 10% showing delayed emptying, and a poor correlation of symptoms between scan results, nausea, vomiting, and early satiation and pain. So let's get down to how we can help these people and how I can manage some of the more difficult ones. Now, current treatment of gastroparesis, trying to correct the underlying medications, conditions, review medications, possibly stop that GLP-1, control the hyperglycemia. Remember, hyperglycemia slows down the GI tract. Hypoglycemia actually creates rapid gastric emptying. We worry about nutrition and hydration. We talked about how I choose enteral feeding, J-tube feeding, which is based on small bowel transit tolerance. We often tout the gastroparetic diet, which is small, frequent meals with less residue, less fat, because these things empty better. But there is some literature evidence for this, but not an overwhelming amount. We'll talk about the medical treatment, and there are behavioral modifications in psychiatric treatment. For failure, some people talk about a decompression PEG tube and a nutrition J tube only after a trial of nasogastric and nasojejunal tubes. So I never marched immediately into a separate through the abdominal wall procedure. I now heavily shun using compression G tubes. It will make people feel better by decompressing, but then their GI tract will get used to a state of deaccommodation, which then leads to the challenge that anytime in the future, they're not going to be able to eat because that stomach will remain collapsed while it's decompressed. They have a chance of losing fluids and electrolytes through that open G tube. And when you try to stretch it out with meals, they will not be able to tolerate it because essentially it's like being gastric bed rest. And as a result, you get a gastric cripple. So I strongly avoid placing in decompression G tubes. I will consider a J tube through the abdominal wall only after NJ tube feeding has been done, trialed, and they can tolerate it. So that means they may be on NJ tube feeding for 3 weeks, 2 months, 3 months to really see if it's worth going to an additional procedure to get that PEG tube done. So in functional dyspepsia, you have a lot of treatments: acid suppression, H. pylori eradication, prokinetic serotonergic agents, and then neuromodulation through pain, visceral analgesics, and non-pharmacological therapy. Reality is most of this will overlap with gastroparesis except for the H. pylori eradication and to the degree the acid suppression. And that's why I find it's because these patients by etiology basically can flip back and forth between gastroparesis and functional dyspepsia. Let's talk about the prokinetics. There are some classes here. I think the biggest challenge about prokinetics is there's some evidence. You have drugs like metoclopramide, erythromycin, domperidone that can move the GI tract. But we'll talk about some of the limitations. And for the most part, I don't use prokinetics as absolute basic, as standalone therapy in my more challenging cases, unless there's moderate to severe delays in gastric emptying. That means greater than 35 to 50% emptying, greater than 35 to 50% retention after 4 hours compared to 10%, less than 10%. So metoclopramide, probably one of the most commonly used ones. Here, the benefit, it comes in IV, PO, and intranasal. But many patients complain of side effects such as anxiety, depression, insomnia, akathisia, skin crawling, acute dystonic reactions, and Parkinsonianism. There's some reports of neurologic malignant syndrome, black box warnings, and tardive dyskinesia. Some reports are as high as 15%, but more detailed studies and large databases now peg that prevalence of less than 1%. With all of that, generally lowest dose and intermittent use is better than chronic use. Some risk factors for complications include age and being female. Another classic is erythromycin. It's a macrolide antibiotic that mimics the action of motilin and induces phase 3 migrating motor complexes. So as a result, it increases antral contractions. Ideal dose is not antibiotic doses at 150 to 300 milligrams. It's actually at 1 to 2 milligrams per kilogram, so about 50 to 100 milligrams by liquid. So liquid is better to empty. The lower dose allows antral contractions and small bowel contractions. High doses give major GI side effects. They may empty the stomach, which is good for clots of blood during endoscopy, but it actually abolishes small bowel transit. So remember, 1 to 2 milligrams per kilogram, and understand also there's tachyphylaxis, so you have to have time on and time off, and it is antibiotic exposure. Although it's a prokinetic, I will tell you right now, I do not use this drug often unless the gastric emptying is greater than 50% delayed, because I find as a standalone, it doesn't help that much. Domperidone, some people get it from Canada. I don't use it until it's FDA approved. It blocks DT receptors and increases local release of acetylcholine. The benefit of domperidone and even metoclopramide is that it helps at multiple fronts. Both these drugs are pro-motility. Both these drugs also cause benefits for nausea and vomiting. So the two together, I think, are a better chance of impacting than just pushing one single drug. Side effects also include prolactin levels, and PO form is available. There are a number of clinical trials and development of this drug of a different form to reduce the cardiac risk factor in the US, and they're still ongoing. This slide just goes over the doses of 10 to 20 milligrams 3 to 4 times a day, resulting in some improvement of symptoms and some improvement of gastric emptying. So in summary, for gastroparetic agents, there's few very large well controls, and many of them actually in the more recent trials have been negative. And that suggests trying to improve the promotility when the poor correlation between symptoms and gastric emptying exists can be a little bit difficult to prove. Symptoms may be improved compared to the placebo, and you get here various results between 8% and 36%. This is actually a forest plot summarizing prokinetic therapy for functional dyspepsia. It seems like it's amazing. The number needed to treat is actually 4 with a relative risk reduction of 47%. But the funnel plot here may suggest that there's a publication bias only presenting normal studies. Normal studies which have positive results. Another big class, so we move from dysmotility to antiemetics. So here, patients may have nausea, vomiting as their primary complaint. They have a whole host of antiemetics here: phenothiazines, antihistamines, anticholinergics. These can change the sensorium and can help with nausea, but slow down the GI tract. We talk about the benefits of dopamine antagonists, which like metoclopramide, which can speed up the GI tract, as well as antiemetic effects. 5-HT3 antagonists, such as ondansetron, also help with nausea and emesis. And there are also NK1 agonists, such as apripitant, which in secondary endpoints for a gastroparesis trial were positive. But many of these medications, particularly the top 3 that I mentioned, cause delays in gastric emptying. Now, there are other ones, such as Marinol, the pharmaceutical grade of THC, which can help with nausea and vomiting, lorazepam, which decreases the sensorium, and prednisone and Haldol. I think one of the biggest challenges of patients that I see is those that get labeled gastroparesis, but really have just abdominal pain. Now, that can be intermittent abdominal pain, which I would label as functional dyspepsia if they have normal gastric emptying, or they may have abdominal pain even with gastroparesis. But pain is a major driving factor And it can be as prevalent as nausea, vomiting, early satiation. It's interesting, historically, abdominal pain was not considered one of the major cardinal symptoms of gastroparesis, but nowadays we recognize that it is a major thing that's driving patients to their care providers. And it can be a challenge because many patients get put on TCAs and narcotics for their abdominal pain. Drugs such as tramadol could be used, but gabapentinoids, such as gabapentin and pregabalin, have less effect on the GI motility. And this is why it's very important to identify pain as part of this complex and target it, not as pain from dysmotility, but pain from visceral hypersensitivity. And so here you need to define the symptom priority. Is it pain or is it nausea, vomiting, early satiation? And distinguish, cyclic vomiting, which has acute, severe bouts of pain, nausea, and vomiting, from the intermittent abdominal pain of gastroparesis or even functional dyspepsia. Now, to address this issue, there have been two trials that I'd like to cite. One is the Norway trial done by the Gastroparesis Consortium. Here, they used nortriptyline rather than amitriptyline because it may have less side effects. And they try to show that you're hoping compared to placebo, there's a decrease in symptom baselines as measured by this patient-reported outcome, the GCSI. And unfortunately, for the primary outcome, they did not show any difference between nortriptyline and placebo when the doses range from 10 to 75 milligrams. There was some higher dose dropout at 29% versus 14%. So this is a little disappointing, but there were other secondary endpoints with the GI symptom scale, which showed there was a reduction in pain in nortriptyline, but the primary outcome of gastroparesis symptoms was not different than placebo. This is in contrast to the TCA amitriptyline story. So here, a separate trial taking not gastropredicts with bona fide upper GI symptoms and delays in gastric emptying. You took patients with functional dyspepsia with just the symptom complex of upper GI symptoms. And here, they got a portion of patients which had postprandial distress syndrome, more the early satiation type, and 30% with a pain type, epigastric pain syndrome. And they compared amitriptyline at 50 milligrams versus SSRI escitalopram at 10 milligrams versus placebo. And the primary outcome was adequate relief for several weeks during the 15-week study. Here, they showed that placebo, if response was 40%, escitalopram was 38%, no difference, and amitriptyline was 53%. And there, that showed that amitriptyline was superior to placebo or escitalopram. In fact, it's the EPS group on amitriptyline which had a threefold more likelihood of getting adequate relief compared to placebo. Now, one key thing here is that when you measure gastric emptyings in all these patients with functional dyspepsia, which is not a requirement for the diagnosis of functional dyspepsia, delayed gastric emptying were less likely to report adequate relief than subjects with normal gastric emptying. What I take away from this is if you have delays in gastric emptying, probably a TCA is not going to be as beneficial. Botox and gastroparesis. People still do it. I don't do it at all because basically there are numerous trials, and with sham controlled, it doesn't show any change in symptoms or gastric emptying scans in the population that they studied. Now, the new kid on the block is GPOMs, the gastric pyloric endoscopic myotomies. And here, it's exciting. It's being done by our therapeutic colleagues or surgeons. To me, this is a more aggressive version of a Botox, and it's unclear about how select patients. Many times, our colleagues have gotten wise that if they have severe abdominal pain, they're not going to do these patients. And now they're trying to see if there are any physiological parameters, such as pyloric stiffness or other sorts of parameters that can help predict which patients respond better. And pyloric stiffness can be measured by endoflip. The bottom line I see here is that this technique is still in early stages, and that there are some placebo-controlled trials which show some benefit that were now out of 1 year, and a ton of case series which have no sham control showing benefit. So we're waiting for larger sham control trials, and I really worry about the placebo effect in these patients. Surgery and gastroparesis. For me, the only role is for the placement of J tubes for enteral nutrition and tube feeding. So no gastrectomies, no partial gastrectomies, no Roux-en-Ys. That can take a patient that has visceral hypersensitivity and make them a lot worse by invading the GI tract, cutting on the vagus nerve, cutting on the muscles and nerve endings, causing more visceral sensitization. Before you put in a J tube, you want to confirm small bowel motility adequacy with either small bowel follow through. Remember, small bowel transit time in the contrast should be less than 2.5 hours, or wireless motility capsule or anterodural manometry. Failure of tube feeding or small bowel function, as I mentioned before, is going to result in TPN with its inherent complications. And from my motility point of view, if a patient is finally relegated to TPN, it's not a motility problem, and I don't manage the TPN. A lot of times, patients complain of challenges with enteral feeding or PO feeding, and this is more an issue with visceral hypersensitivity, where necessitating treating with neuromodulation, whether that be with TCAs, with gabapentin, with other sorts of options. And I strongly, again, discourage G-tube drainage because it causes loss of accommodation. You may have heard of gastric stimulators. We don't place them because they don't necessarily increase gastric emptying, but they do modulate the vagus nerve in some way, and that can be appealing. There are now versions of ear vagal nerve stimulators and neck vagal nerve stimulators that are being evaluated for upper GI symptoms, functional dyspepsia, and gastroparesis. There are a number of studies, but no large-scale randomized placebo-controlled studies. And basically, it shows that it improves some nausea and vomiting in about half the patients, and some impact on TPM and glycemic control, but not helpful for pain, not improving gastric emptying, not improving electrical rhythm. So it might be better in diabetics compared to non-diabetics in certain groups, but this is limited access because many places don't place these. To place them, you have to have a committed gastroenterologist and a committed surgeon. There are drug trials in gastroparesis, but I updated this list, and I think the future for this is challenging. I wouldn't say absolutely bleak, but challenging, because here now I list the number of agents, 5-HT localized agents have been halted in development in phase 3. The Bushburn study, actually produced by the NIH, had negative results, despite earlier small study phase 2 being positive. Domperidone-related compounds are still pending. It's been a challenge for recruitment of patients, even though they're out there. It's difficult to get them in the studies. Nasal metoclopramide for diabetic gastroparesis actually has been approved, and so that's the one shining light in this process. But another trial with NK modulators in phase 3 showed a negative trial, and ghrelin agonists showed some mixed results, but were halted in phase 2. Other components to treat include behavioral therapy, and this is where I find teaching of being aware of the fear of eating. Some of the most severe referrals for gastroparesis are really people that have lost dramatic amounts of weight, they're wasting away, and they do a gastric emptying measure. It's abnormal. It's abnormal because they don't use the GI tract for months or years at a time, and it's the pain that causes behavior of avoiding food. And so this actually can be treated with neuromodulators, but if identified, it might be ARFID, which can be treated by cognitive behavioral therapy and coping mechanisms. And so there are more studies to come out of this, but you will hear this term, and frequently I apply this in the right patient population for some of my most challenging patients to deal with. So as a result, psychology, cognitive behavioral therapy, hypnosis are options, and they can improve symptoms in functional dyspepsia, more to come with gastroparesis. Acupuncture has been shown for nausea, and there's some randomized controlled trials for acupuncture and functional dyspepsia, but not yet for gastroparesis. And finally, briefly, cyclic vomiting syndrome. This can be confused with gastroparesis because they have overlapping severe nausea, vomiting, and pain episodes, which end up in ER visits, but it's different than gastroparesis because in between patients are fine, whereas gastroparesis usually have daily or multiple times a week symptoms. And so the key thing here to understand is the treatment of CVS is so distinct from gastroparesis and functional dyspepsia. And if you can identify these patients, you can make an impact. So CVS is defined by periodic episodes of vomiting with sudden acute or severe attacks, duration usually lasting less than 1 week, and having 3 or more discrete episodes in the prior year, an absence of symptoms in between attacks. That's so important. That's different than a patient that has chronic daily symptoms with functional dyspepsia or gastroparesis or chronic nausea. And I also want to make a point. There's a difference between CVS and cannabinoid hyperemesis. It's easy to write these people off who take a small whiff of CBD or of smoking marijuana, to write them off as cannabinoid hyperemesis. But the reality is the definition is strict. They have to have chronic high use of cannabis and recession of symptoms after 2 months of withdrawal of any cannabis use. Most people, in fact, very rarely do patients actually meet this criteria. They may withdraw the cannabis, but they're not dramatically better with their symptoms, or they have not a significant high chronic use of cannabis. The key issue here is, I find, patients do not get prophylaxis treatment. They come into the hospital, they get acutely treated, and here you want to calm down the GI tract and the autonomic storm aggressively with benzodiazepines, possibly ketamine, and I avoid narcotics in setting an acute care plan in place. But they miss out on the chronic neuromodulations that's necessary for prophylaxis. So that chronic prophylaxis is right here. First line TCA, such as amitriptyline, nortriptyline, and if they fail, stacking other medications below. And then below that are the aggressive treatments for prodrome or acute treatment in the ER, IV or PO, antiemetics, migraine medications, and such. So in summary, in challenging cases of gastroparesis, I really think about the symptom complex, whether it's nausea, vomiting, where I treat it with antiemetics and visceral hypersensitivity, early satiation or poor gastric accommodation, where I may push some promotility agents or fundic relaxants or neuromodulators, or if pain is pushing the symptom with visceral hypersensitivity, and I focus on neuromodulators and CBT. Thank you very much.